Um, Good morning, good afternoon, good evening, whenever you are. Welcome to INRIPAUC's first international online networking event. At the second last session. I just have a few practical bits of information before we start. So this session is recorded, only the official part of it, if you will, the question and answer session afterwards will not be recorded. I did have a poll, but seeing that as we are quite few people, I think we'll skip that. And then I want to draw your attention to the event Padlet in a minute and ways of being involved. And then we'll have the talk. And then any questions you might have or comments, we can deal with that afterwards. So we would very much like the contributions from the membership. So all of this week, we are using a Padlet tool online with some questions. If you go to your delegate pack on page 8, there's a link, and we would very much appreciate your comments. Just remember, if you go online and make comments on the Padlet, remember to click on the arrow when you make a comment, because otherwise it's not submitted to the database. We had a facilitated session this afternoon where we went through the answers we'd received so far and had some discussions. So eventually we hope to write some definitions and answers to these questions on a website that we will be working on establishing. Ways of being involved. If you're not already a member of our LinkedIn group, please find the group and request membership, and we are welcoming anybody who wants to be involved in this group and who are interested in understanding how people learn to live well with a long-term condition. You might want to be more actively involved. Then you can either become a member of the Lived Experience group. If you're interested in that, please contact Steph Kilic. Her email address is below on the slide, or you can contact her through the LinkedIn group. If you are interested in being involved in other things, such as the leadership board or research collaborations or anything else, please contact myself. Again, the email below on the slide, or you can contact me through the LinkedIn group. I would now like to hand over to Alex Farrington. I'll just stop the screen sharing. Alex is our in-training representative on the leadership board. He has just finished a period of being an assistant psychologist at a neuropsychology department. He can tell you a little bit more about that in a minute. Alex has chosen to do this in the form of a conversation. So, Alex, do you think we can get the screens?
Yeah, sure.
Yes, there we are. Excellent. So basically, this is going to be a little chat. So could you first tell us a little bit about where you have been working and what it was like to work in a neuropsychology service?
Of course. Hi, Liz. Thanks for having me along. And hi, Steph and Rasha, who've joined us for the live version today. Do feel free to use the chat, both of you, if you have any questions along or you want to share why you're here today. And yeah, Liz, the first question about where I've been working. That's been at Adam Brooks Hospital in the neuropsychology department there. So I've been working in an acute hospital, and it's the regional major trauma centre in that area. So the team I was working in was quite a small team, consisting of clinical psychologists, working with both inpatients and outpatients. So two separate teams there. When I was working on the inpatient team, I was working with people who had traumatic brain injuries, different neurological conditions, and things like stroke, epilepsy, encephalitis, really difficult conditions that patients can have and may need to adjust to, of course. And also with the outpatient service, that was more of a diagnostic. We're also working with patients who may potentially have dementia or some other kind of organic change in their brain. So that was really about conducting cognitive tests and things to try and understand what the changes were in that person's cognition, and to support them and the families with that, because it's such a huge thing for a lot of people having that change. So yeah, that was the service really, which I was involved in.
Mm-hmm. So it sounds like it was really almost anything that can happen to the brain that you were involved in. Sounds like a fantastic broad experience you've had. But what sort of experience did you have before this role? What made you ready, if you will, to engage in that kind of work?
Oh, that's a good question. How did I get there? Yeah, well, I think the first role that I started in, well, I worked at Clinton's Cards to begin with. That was my first job. But
sorry, what was that?
Clinton's Cards. It was a retail role. While I was at university, but more going into the clinical work. I was a support worker to begin with, so working with people who have long-term conditions. I worked with a person who had adult onset epilepsy, a person who had learning disabilities, and their families as well, because when a person has a chronic condition, it's not just themselves who's affected, it's their whole entire support network as well. So I think having a support worker there in that network can be really helpful to just work through any of the barriers that are involved in that process. Then I was working in mental health after that. So working with people who have anxiety and depression, as a psychological wellbeing practitioner. What we know about anxiety and depression is that if a person has a chronic condition, often that can be one of the underlying factors that can be contributing to how a person feels. So a really rewarding role really to help some of the people move through that process and deal with what's on the face of things, which is how they're feeling, that lowness and that worry.
Mm-hmm. Great. So if we go back to the neuropsychology experience you've had, so what sort of things did you do there, and what was a typical day like there?
Oh, it was really varied, really varied. No days were the same. A lot of cognitive tests, though, and I think that's one of the really important parts in that acute stage, is understanding what's happened so a person can plan for what's next, really. And I know we've had conversations in the past about this taking stock stage of adjustment, and what that question is really is as you said, what's next? And I think the more that we can understand a person's change in cognition, the more we can help the families and themselves plan for the future. Whether that's say, for example, with a dementia, if a person receives a diagnosis of a dementia, getting them in touch with the local support networks, and the medical side of things, making sure that they have the right support and medication for that disease.
Mm-hmm.
So we work very closely with the memory clinic to help them do that. We're not a medical team in neuropsychology, but I think they really valued the cognitive test which we will be able to provide, and the emotional support that we were able to provide the patients with.
Mm-hmm.
It's a huge thing, having a diagnosis, having a life-changing injury.
Mm-hmm.
So really being there to listen, and to give the patient time if they were an inpatient, for example, to listen to sort of what's changed for them, and how that might impact their future lives when they eventually, which they will return, go away from hospital and back to home or a different place.
I can't help wondering, do you at that relatively early stage, do you already teach them some strategies for instance, memory strategies, or could you talk a little bit about that?
Quite basic strategies I think are helpful at an early stage, because there's so much going on for a person when they're in hospital for the first time, have had changes, whether that's physical changes in their appearance, due to an injury, or coming to terms with the change in their cognition. Helping people stay orientated is really important so that they can feel safe.
And how do you do that, for instance?
Simple things like the date and time, helping them understand where they are. Because when a person's had a bang on the head, they may not understand that they're actually in hospital, depending on sort of where it's been affected. They may not be able to lay down new memories. And that can be really disorientating for a person, because imagine during COVID times, there's a lot of people in a hospital wearing masks, coming to see you at your bedside. It's disorientating at the best of times. So helping the patient feel comfortable in that environment, I think, is a really important first step.
Sounds good.
Yeah.
I mean, when we talk about psychosocial adjustment, which we have tried to define this afternoon, but this coming to terms, that's one of your expressions is coming to terms, but it's more than that. But it's this whole change that has happened for people and how they change their life accordingly. We think about that as a long-term process, but what would you say, other than what you've already said, what does it look like in the acute stage? It sounds like you can't really begin to do an awful lot in terms of self-management and strategies at that stage. So,
I think helping the person with like sort of their emotions, but yeah, you're right. Adjustment's a long process, and I think that when I seen patients, they were very much in that early stage, that very acute.
So it's really the emotional reaction to it, and just getting their head around that something really bad has happened.
Yeah, exactly.
And support around that, and and I guess also support for the family.
Yeah, I think a lot of the times when a patient's had an injury like that, we can feel like we want to do a lot and to try and as professionals, that's how we should feel. But sometimes one of the best approaches, I think, with family members, I found, was just helping to let the air out, and similarly with the professionals who were working with patients each day. For example, like speech and language therapists or occupational therapists, patients may be having a really difficult time in hospital, feeling quite low. So supporting the professionals, in that sense, with things like, behavioural guidelines, helping the patient, understanding the patient's interests, likes and dislikes, and making it a bit more of a person-centered approach in a very medical environment. Yeah.
Good. You mentioned something earlier, taking stock. So I was wondering if you could sort of expand a little bit on where does that term come from, and what does it mean?
I think thinking about the adjustment research, it comes straight after the event which triggers adjustment. Is how I like to think about it, and I think that's what the research suggests as well. And it's that initial stage. Okay, this has happened. What are we going to do now? What change needs to occur in order us to adjust? It's that first initial stage, I think, and quite a difficult stage, I think, in the whole process.
I'm sure, yeah. So what were the main barriers you came across to taking stock?
Understanding of the injury was quite a big one, I think. Especially with like something like a brain injury. Sometimes there's not a lot of visible physical change. Sometimes there is. But a person may feel on the front of things that they're okay, but have actually experienced a lot of cognitive changes, which excuse me, can be quite difficult. So I think education is really important there, and building insight into what those changes mean. Likewise for the family, I think that was really important, especially during the start of lockdown. I suppose when we're speaking here, the country that I'm working from has undergone lockdowns like many other countries have. So family support in the hospital is quite difficult because of visiting hours being restricted. Thankfully, at the end of sort of my time there, visitors were allowed back in, but a lot of that was over the telephone, you know, describing to family members, you know, how their loved one is, and what their injury actually means. Because when visiting hours were restricted, family members were only allowed to come in for an hour a day. And you know, when we're thinking about adjustment on a whole, if a family member only sees the patient or the person for 1 hour, you know, how does that affect their lives when they then leave hospital? Oh God, frog in my throat.
Yeah.
Bear with me, listen.
That's okay. Yeah, you just take your time. Well, it sounds like you've been, that there has been sort of a good focus on actually also thinking about supporting the family, and that's really great. So, what would you say? What kind of things helped people at this early stage of adjustment? What did you see as the most helpful and beneficial?
It's all up saying to them that it's all okay. You know, yes, they have experienced a very big change, but that they still are in the very early stages of recovery. For that's very much for things like traumatic brain injury, where recovery is part of their journey. But in terms of,
can I ask, when you say it's all okay, I suppose you mean it's normal to have these reactions, and it's normal to the kind of experiences they have are normal for what has happened to them, so they don't get too scared, I suppose. Yeah.
And that message is really difficult for people, you know, depending on the backgrounds that they come from. They may have lost a huge amount because of their injury and change. So yeah.
What else? Anything else that you think helped at the early stage?
Yeah. Trying to get a clearer message across with the other professionals as well. So a person, when they're in the hospital as an inpatient, you know, can have lots of different people working with them, for different reasons, whether it be mobility, with physios, sort of speech and language with their speech. So trying to get like a clear message across can be helpful, and that really comes down to working, you know, together.
And when you say clear message, what do you mean? A clear message of what? Because I didn't get that clear message.
Oh yeah. So when I mean clear message, you know, I think in the hospital as an inpatient, quite often patients are working towards small goals. The long-term goal is to get better, of course, is to leave hospital and for life to be like normal. But that can be often quite difficult while in that early stage to think about that, quite overwhelming for a patient. So I guess the clear message is having a clear goal to work towards in that short space of time while they're rehabilitating. And for that to be shared across the different professionals as well. So quite often what I found helped was doing joint sessions with other professionals. So if a patient was worried about their mobility, you know, and we're in a physio session and finding it really difficult, then it was quite helpful for me to be along then, and you know, working with worry management techniques, just to keep that message clear. Yes, you were worried, but it's going to be all okay. Yeah.
Great, thank you. So you talked about before adjustment research, which obviously has really proliferated the last 10 years or so. So what's it been like applying adjustment research in a practice situation?
Quite difficult. It's a really fast-moving environment, the hospital. And I suppose one thing I found helpful is always having the adjustment research in my mind when working with patients. But I think, you know, one thing moving forward that might be helpful is to sort of have this process in mind across the disciplines, and to view it as, yes, this person is in this early stage, and taking stock. Okay, what else can we do now to help perhaps prevent barriers further along the road in that journey? Yeah.
So you're almost saying if all professionals were to sort of share a model of
I think so.
What is this like? Then you could more easily work interdisciplinary. Is that what you're saying? Yeah. Well,
I don't know if that's idealistic thinking on my part, but I would like that to see. I like to see.
You're not. Let me say, you're not the only idealist, but it might take some time. So, but hopefully we'll get there eventually. So I know that you are embarking on training as a clinical psychologist now. How do you think that compares with neuropsychology?
I'm hoping perhaps in the future, well, I'm hoping that they combine at some point. I know in the course that I'm going to do, there'll be elements of neuropsychology, which is what I'm interested in. So I'm hoping that they both combine. Yeah, is the answer. And that thread of sort of the adjustment research, because neurological conditions are so difficult for a lot of people. I'm hoping that that continues to be a thread in my career.
I don't know if you're aware, but actually neuropsychology is something you take after. It's a post doctoral training which you access after having trained as a clinical psychologist. But you are absolutely right, it probably should be more prominent at an earlier stage.
I don't know if I can think about after that. Yeah.
No, that's probably wise. So, but I think also you might be able to actually contribute to your clinical training with your knowledge of adjustment and adjustment research.
Hope so. Yeah.
Because it's not that widespread yet, and so you have a mission there. So on behalf of INRI Park to spread some knowledge. So but we're coming sort of to the end of this. So is there anything more you want to say? Anything, maybe a message for other trainees that might look at this session at some point?
Yeah, just to thank you, Liz, and thank you everyone who's going to view this and who's viewing it right now. I don't know if anybody has any questions, whether that be about adjustment.
Just wait with that for a moment. But so you don't have any further comments as such?
No, that's okay.
Yeah, because I wanted to stop the recording before we take questions. So just a second. But thank you very much for your contribution.